Okay, the recording has started.
All right. Thank you, Karen. Thank you, everybody, for being here. Appreciate all the interest in this. This is DCBS Rulemaking Advisory Committee related to implementation of 2025 Senate Bill 692, which relates to coverage of various perinatal services by insurance. Um, I did want to just up at the top apologize for having the sort of chaotic scheduling around this. I had some unavoidable family things that were happening a couple weeks ago and was forced to cancel the first instance of this meeting with fairly short notice. And certainly we could have handled that better, and wanted to make sure that I had sincere apologies extended out there and make sure that we're having this process go as smoothly as possible moving forward, all things considered. We have a very large group in the call. Normally with a sort of with rulemaking committee meeting like this, we will have sort of the set panel of people who are participants, and then only kind of reserves a small period of time for public comment for the sort of general public, interested parties, et cetera, et cetera. I think like because this is a little bit outside of our normal bailiwick in terms of stakeholders, I feel like my sort of initial invite list is not particularly well matched with the people who are actually best suited to be speaking to this. Like typically our rulemaking, since we're the insurance regulator, will have a pretty heavily weighted panel towards insurance stakeholders who are the directly regulated entities and not necessarily have a wide spectrum of providers. Um, I think that we should consider this. And I guess I should introduce myself too. Numi Rayfield Griffith, Senior Policy Advisor with DCBS DFR, Division of Financial Regulation at the Department of Consumer and Business Services. Use she, her pronouns, and I'm going to be running the various rulemaking processes that on our side, as well as coordinating with the Oregon Health Authority on their portions of implementation for this bill. Um, and I apologize for being a little bit scattered. I got home to Salem pretty late last night after being out of town for a few days. So, okay. Um, so this is a little bit of an unusual situation for rulemaking because a lot of what we are working with is somewhat dependent on work that's being conducted at the Oregon Health Authority, which has sort of a much bigger portion of work associated with this bill than we do. Um, and so, kind of our plan at this point is to move forward with a temporary rule, which is going to be in place for January 1 implementation of the portions that we think are kind of ready to go. And yes, thank you. Thank you, Andy. So rather than calling roll, I'm going to say it's like I'll run this a little bit more casually than I would sort of a rack for permanent rulemaking. We're just going to be filing the temporary rule for January 1, and we'll have a more formal process for the permanent rulemaking next year after we're more ready to kind of move forward with things. Um, so just the sort of general call would be for folks to, first time you speak up, other than myself, please introduce yourself and who you're representing, just so everybody knows who's speaking. We're just going to basically use the team's attendance list as our roll call. And I'm going to go ahead and dive right into it. So I think the sort of big thing is what we're not doing today. And if you have questions or want to bring up a point, please feel free to use the raise hand function, and uh, I'll call on folks as soon as I finish my previous thought. Um, we are delaying a portion of what is supposed to be in place on January 1. And that is because it is very much so there's sort of two things that are in our rule, one of which is coverage of services provided by doulas on the one hand, and then on the other hand is services that are being covered on under what I'll term broadly as lactation professionals, so which are identified as lactation counselors and lactation educators in the bill, I believe. Um, we've been in communications with the Oregon Health Authority, which is working on a rule through the Health Licensing Office to define some parameters for sort of scope of practice for those categories of professional. And my understanding is that there will be a bill coming in the short session this year that's going to push out the timeline for a little bit to make it a bit more manageable. In terms of what we're doing, we don't we we don't feel really able to point towards a definition of the scope of practice for the types of professionals who would be covered under those two categories. So sort of lactation professionals, where uh, we're looking to have sort of a more firm source of authority to point to. And as the insurance regulator, we don't have the level of expertise to define that by rule ourselves. And I think that going along with the direction in the statute that we're supposed to coordinate with the health authority and to issue guidance that is in alignment with their work implementing the bill, like we're going to push back that portion of the bill for our side as well. And the sort of thing on their side is that they have pushed back their rulemaking process related to the lactation professional portion of the bill until at least March of 2026. So they're planning to have a rulemaking advisory committee that's going to start meeting after the short session, presumably after any changes to the statute have been made. And that at that point, we're going to go ahead and move forward with a permanent rule that's hopefully able to point towards authority that has been issued by the Health Licensing Office at this point. I did have Karen distribute a letter, a memorandum that I had drafted that is kind of going over more or less the things that I just said, why we're not going to be pushing forward guidance related to the lactation professionals for plan year 2026. And also kind of going over the background of what OHA has been communicating in regards to this. So most likely we'll be looking to have some clarifying language in the same bill that is also pushing back the sort of implementation date for those portions of the bill to most likely plan year 2027. We're not really able to effectively enforce new laws that kind of come in mid-plan year. So it's really something that kind of goes from a date when at which things are applicable to new contracts or contracts that are renewed. So that's kind of the way that things are usually written for timing. So that was me talking a whole lot. And we haven't gotten to the sort of draft rule text at this point either. Are there any questions or comments at this point kind of on this whole sort of approach, on the delay, on the reasons behind it, or I think we have a pretty doula heavy group, so maybe there's less concern about the lactation professional side of things, but be happy to take feedback at this point. Antoinette, go ahead.
Yes, hi, this is Antoinette watching from Cambia Health Solutions. So in reading through the memo too, I think I think I saw that we are also delaying the requirement in the bill that requires for the coverage benefit limit to be adjusted annually. I think I thought I saw in the memo that we will be addressing that when the RAC reconvenes in March and April
Well,
to basic. Okay.
So I do have in the draft rule for January 1 the sort of coverage limit, which is basically just copied over from the statute. So
Mhm.
having kind of the same value for 2026 as has been placed in law as the sort of payment cap for
Yeah.
the services. So like I'm not going to try and do an inflation adjustment in the temporal. My expectation is that, you know, we'll be revisiting the coverage limit in the sort of permanent rulemaking, and just because of the nature of how the Oregon Constitution limits rulemaking authority, the the we'll have to do sort of full rulemaking to update the rule with the current inflation adjustment every year that's pushing that up. So kind of my plan on that side of things is to have the statutory limit set for 26, so exactly as it's stated. And then we'll be doing a rulemaking advisory committee process as well as a permanent rulemaking filing for plan year 2027 that is going to contain the first inflation adjustment. So that's going to be in process, hopefully Marchish. We'll see how things go in the session, as well as like how able OHA has been to move forward with their process in terms of the rulemaking they're conducting related to this bill. So the answer is no, we're not delaying the coverage limit language, but we are pushing back the any inflation adjustment until at least 27, plan year 27. Does that make sense?
Oh yeah. No, I'm not disputing what you specified in that memo at all. I just want to make sure that when the RAC reconvenes early in 2026, the purpose really will be to also address the monetary cap, right? Benefit amount. So that's all I wanted to make sure that it's addressed, because I think you were talking more about the delay of lactation professionals.
Yes.
But I just wanted to make sure that I am also reading the memo correctly, that that monetary amount, which is tied to the CPI, will be also addressed at that time for the next calendar year.
Yes. Yeah. No. So that is basically the plan moving forward, and hopefully we'll be able to nail things down a little bit more firmly come March.
Great. Thanks, Numi.
No problem. Scott, go ahead.
Hi, afternoon, Numi. Scott White from Moda Health. I just had a question. Maybe, Numi, can you help clarify some of this regarding coverage limits for lactation, education, and support? Because from an ACA mandate standpoint, we cover lactation services, equipment, support for the duration of breastfeeding without cost sharing. So I'm trying to see why it was important to have limits there at all when we really don't have any under the ACA that we're placing on that, other than that it's, the duration of breastfeeding.
Yeah, I mean, I can't speak necessarily to the motivation in the drafting of the bill. Dana, did you have a comment that was related to the background on that, or should I
related to Scott's
answering?
Question?
Yeah. Related to Scott's question? Yes.
Yeah.
Okay.
Do you want me to jump in, Numi?
No, please. Go ahead.
In conversations with the Oregon Health Authority, they have interpreted the cap not to apply to the lactation component. And so I think that's one of the things we can make sure is clarified in the statutory fix, that the lactation piece could live outside the cap due to what you're saying, Scott, which is that it's already mandated in federal law and under the ACA, that lactation services should be included in coverage as needed.
Thank you, Dana, for the clarification.
Yeah, thank you, Dana, for jumping in on that. It's like I recognize I'm not necessarily the most knowledgeable person on this specific area of coverage. So, okay. other questions, thoughts sort of on the broad picture plan? Nolan?
Hi, my name is Raven Nolan. I'm yeah, no, that's totally fine. And I've been a doula for a really long time. I'm one of the co-founders of the Oregon Doula Association, current vice president. I'm also the doula program coordinator for Legacy Health Systems doula program. And I am wondering, so I think it's really smart that we are, and I applaud everybody that we're pausing the lactation piece, because yeah, those pieces are not built out yet. For the doula piece, I would also strongly suggest that it's only half built out. OHA has a robust outlining of what birth doulas are and birth doula coverage benefit. And there is a separate type of work called postpartum doula work that is not built out at OHA yet. And that is what it seems like a lot of the rules are pointing to, especially with the extended hours. So I am wondering, big picture, like if this is just a temporary rule, would it be appropriate to also pause like the postpartum implementation of it until that had rules built around it? I am like very excited to get that going and don't want to pull the brakes on it, but also don't want to get ahead of things inappropriately. So just wanted to put that out there and hear the thoughts on that process.
Yeah, I mean, like speaking as a representative of the agency, sort of our duty in relation to this is to execute the law as faithfully as we can to what's been written. So like, I'm not like sort of by default, like if the position of the doula community would be like, no, let's move forward with this, then it's like, okay, we're going to do the best that we can. If there was a consensus from the advocates representing the doula community that was saying it's like, okay, we need more clarification around this before this is operating, then I would say, okay, then I would be comfortable to kind of say, it's like, oh, okay, yeah, no, it would make sense at this point to have a delay in implementation. I recognize that there are some outstanding questions around things, particularly with the sort of the post-birth side of things for doulas specifically, and where that is really kind of in connection with some questions about what is considered medical care that is coverable and what is not. And that was something that came up during the session that I don't think was fully resolved in conversation with the carriers and the advocates. So, I mean, that's still out there. So like, if I get a strong signal that's saying it's like, okay, we want to push this back for clarity, but kind of like if we can move forward with what we have and recognizing there is some ambiguity and just the nature of temporal is that it is effective for a maximum of basically 6 months. And that's going to be something where we're going to have a new rule in place after that, just by necessity. So yeah. So I don't have a firm answer on that necessarily, other than to say it's like if I heard a really strong signal that is like, okay, we're not ready to do this, then that would be something that I would take under advisement and also like talk to OHA about integrating that into the legislative fix that's already coming. But if I'm not hearing that, then I think we move forward with what we have. So, okay. Looks like my next hand is from Antoinette.
Yeah, hi, and I have just two comments. And in response to the current one, which was like delaying the postpartum part of the doula Coverage services, I mean, I should caution also, and I agree with you, Numi, with currently the DFR's position on this. It seems like the coverage requirements for doula services is quite clear. But I caution that if the postpartum part is being requested, that it also be delayed. We should also consider like the billing aspect of it. Is there are there billing codes like already in place where only the pre and during labor services are covered? I just want us to caution if we're delaying any aspect of the doula services, breaking it up until later. Um, and my other comment or question is that relating to the coverage of lactation professionals under the ACA, yeah, if they meet the ACA requirements, of course, it's covered at no cost share. So I'm curious to find out with the scope of practice for the lactation professionals in Oregon, when would that come into play? Because we're delaying that aspect of it until, the OHA prescribes some requirements and scope of practice for the lactation professional. So when would that come into play with respect to this mandate?
For commercial,
Yeah.
I think what I have talked with people about in terms of the sort of effective date for a pushback is like if there's a legislative change, like I would be looking at basically contracts entered, renewed, or extended on or after Jan 1 of 27. And kind of because of what I had mentioned before about interrupting plan years, it's like generally that's the way our statutes are written, and the way that we apply things is kind of going from calendar year to calendar year as kind of a cutoff of what applies before, what applies after. So that's probably what I would look to. I mean, it
I'm not
depends.
talking, and I'm not talking so much of the effective date. I just want to know when we would have to pay according to this scope of practice. You mean if the lactation professionals do not qualify under the ACA, is this are we looking for this to be the default?
I mean, I think right now we're looking to say that we're not giving direction on the lactation professional side of things, because like we don't have enough information to do anything on that yet. And kind of limiting the conversation to talking about the doula coverage mandate. I think it sounds to me like potentially the coverage that a lot of carriers are giving is already potentially more generous than the minimum that's required under the bill. But I mean, it is what it is. I saw a hand from Jesse and then Dana again.
Thank you. I'm Jessie Reamer, and I have an Oregon Health Authority approved birth doula training. I've been a doula for 30 plus years in the Portland metro area, and I've also been a postpartum doula trainer for a decade. I'm interested in this process. I just want to get a clarification. It sounds like you said if something were to move into implementation on January 1, that there's still this kind of review process that would be around the 6-month mark that would potentially renew it. And I'm curious about that because we do already have some postpartum billing in place because of our global and the postpartum and our flex visits that are built into the doula role. And in our discussions, we've also looked at what it would look like to add some addendum to the longer births. When a birth is a 3-day long birth, it seems really inequitable, for example, to have it be only represented by one portion of this fee. So I'm just curious how that fits into this conversation.
Yeah, thanks, Jesse, for the question. I think that's probably a little bit of above my head in terms of thinking about the sort of specifics of scope of practice and the nature of services. So I can try and get some more information and think about that, and certainly take those comments under advisement moving forward for as we're thinking about drafting permanent rules. I do wonder if some of that conversation is more appropriate for the OHA process in relation to this. That kind of our domain on the DCBS side is like, okay, you have to pay for the carrier has to pay for this, and they don't have to pay for that, right? And and that the scope of what fits into which basket is probably going to be very dependent on what OHA ultimately lands on. I see you put your hand back up, Jesse. Is that residual or?
Oh,
okay.
no, I didn't do anything. I just didn't probably lower it. Sorry about that. Thank you.
No worries. Dana, go ahead. Still muted.
Didn't unmute myself, lowered my hand. I didn't introduce myself last time. Dana Hepper. I work at the Children's Institute. We worked really closely with a number of the doulas and private insurers on this call on the finalization of the SB 692 language and advocacy in the legislature. And just wanted to affirm, Numi, what you're saying. It makes sense to me to have the lactation counselors and educators start in 2027, January 1st, 2027. That gives us all the time after the 2026 short session to prepare, and also wanted to affirm that it's been my understanding through the process that it would be the intention of the private insurers to utilize the Oregon Health Authority registry as the demonstration that a doula should be able to bill insurance, and that the current doulas under the registry are birth doulas. However, I think what is probably maybe not as well understood outside of the doula community is that birth doulas do prenatal visits, support birth, and also do some postpartum visits as a birth doula. And so we do want to make sure that people that are currently registered with OHA are able to now, under this new legislation, bill clients that have private insurance, in particular because we see birth disparities, especially for African American moms, Native moms, regardless of income, and need that doula support across the income continuum that is prenatal birth and during the postpartum period. And of course, there will be time as this evolves to allow for a greater distinction between the scope of a birth doula and the scope of the postpartum doula. That doesn't exist yet. But I do appreciate that the way that you've drafted the rule set, Numi, allows for flexibility in this time of transition. And then that next rule set can be more precise about those scopes.
Yeah, thanks, Dana. And I feel like that's Donna. Is that right? Dana, Banana,
Rosanna, Dana. That's me.
Okay. Sorry, I'm having a terrible time with names today, apparently, and like that's also just partially because like my default is always last name first because we can't change our settings on our team's account at the agency. Anyway, sorry. Zoe, if you had a comment to add on this, I'll go ahead and say go ahead.
I wanted to reiterate what Dana said. There is urgency, and I love the process that you're putting together that allows us to relook at it, but addresses that urgency for families and mamas that will be pregnant in January. So I love that is pressing forward, and that there will be time for us to look at how that process has unfolded. So I just wanted to piggyback and say I agree.
Okay, no, I appreciate that. I feel like that sort of last little bit was a good transition into just taking a look at the temp rule text that I have drafted. And Karen, if you could pull that up. So this is very high level, simple. And I think just kind of trying to address things to the extent that they need to be. Really, I came into this with the idea of basically three things. It's like, well, one of which is the communications piece, one of which is what services are covered or what types of provider are covered. And the third one was like just directly addressing the sort of dollar limit. I think even though I've drafted this in a way that is kind of nested differently from the order I'll go into it, is to start sort of at the simplest level and then maybe kind of work backwards. So I'll start with my subsection 2, which is the communication part of this, is just to say almost exactly what it says in the statute. A carrier must tell members on how they can access doula services. I think that there have been some requests from carriers for sort of more detailed guidance on that. I think that for the purposes of this, as it's going to be potentially fluid for this first sort of 2 years of implementation at least, is to kind of keep this at the most highest level, which is some sort of communication needs to go out to all of your members that gives guidance on this, or there needs to be responsive communications to people who might be interested in accessing doula services. And really the sort of more nitty gritty of like, is it enough to send an email? Do you need to send a letter to all of your members? Do you need to have a page that is in your member manual that says, here's everything you need to know about doulas and lactation counselors? Like that's sort of information that we'll be addressing on the forms side rather than going to great detail in the administrative rule level. So that's kind of the thought about section 2 relating to notifying people. Any questions, comments, etc.? Antoinette, go ahead.
Yeah, hi, this is Antoinette from Cambia Health again. So I understand what I'm hearing is that the DFR is leaving it to the insurer's discretion in terms of how they communicate this to members on how members can access doula services. So it could be as posting something on our website or sending letters to our members or including something in our policy forms. I think that's what you meant by handbook.
Yeah.
Is that what? Okay. So
yes.
You're basically leaving this to the discretion of the insurer as long as it's communicated somehow to our members.
Yeah, that's sort of the level that I'm looking to do at the rule level right now. In terms of like future plan years, like maybe that's something we will drill down more. But like right now, particularly because we are almost in November, like certainly like I'm not going to write a rule that says you need to add a page on doulas to your forms for every member that's getting paperwork. I think the language is specific enough to say that you need to communicate with all members. So it needs to be something that is going out to all members in one way or another, whether that is a mailer or if that is a email or if that is just a page in the forms documents. Like those are all things that go out to all members. But where it feels to me like something that is not just having a page on your website doesn't necessarily feel like it makes it to me. Does that make sense at this point?
Well,
Antoinette?
yeah, and I think maybe we should expand a little bit on access to doula services, meaning that point, I guess I'm trying to like interpret what that actually means. Does it mean informing members of how to get a doula service, like a list of providers that provide doula services? Is that what is meant by this?
I mean, I think that's something that we can drill down on a little bit more next year. Yeah, I did discuss this with Senator Reynolds a little bit,
Mhm.
and kind of what she seemed interested in was like having something that's in the form documents that go out to everybody. And that it doesn't feel sufficient to me, for instance, to have doulas listed in your provider directory. That doesn't feel sufficient to me. So like I think that like there's a lot of room to get more specific on this. So what my main thing right now is trying to get some level of guidance in place for January 1. And that will have something a little bit more specific in the future. Not
Just
necessarily, but largely leaving it up to discretion for the sort of January 1 effective date.
okay. So, I mean, currently we do in our policy forms, and for those that don't know what that means on this call, in our benefit booklets, this is the policies that are issued to our members. We do include language in there that, you know, the services of a doula is provided. So I'm assuming that is sufficient. Or are you saying it's not? Because I'm so sort of
That
for
feels
January 1st,
sufficient. That feels
that is
sufficient
sufficient.
to me
Okay,
for
okay,
January 1.
okay. And I'm hoping that
And
maybe we,
there will be more conversation on this in the future. It's just kind of, yeah. I think that's sufficient for now,
okay,
for January 1, and we'll get consideration on like what the legislature really was wanting to get to
yeah.
in the future conversations.
Okay. And then I have an adjacent comment related to that. And I think in the rules, we would like to request for it to specify, for example, those types of services that or non-medical services support that are excluded for coverage, because of course doula services are not considered, and this is on the commercial side, right? Doula services are not considered medical services expenses by the IRS, and of course for our members it could create a tax implication. So to avoid this tax implication, you know, and also align with, you know, medical policy, um, I think it will be very beneficial and for members, for the rules to clarify that doula services obviously are not considered a medical services expense. And examples of what those non-medical services support are, you know, and of course we know providing housekeeping, childcare, massage, aromatherapy, that those sites sort of services are not really considered medical. So we would really highly recommend that the rules specify something to that effect.
Okay. So I hear you. And we did have some conversations kind of around adjacent to this back in session. So like certainly I'm aware that I didn't feel like it was an issue that the book was completely closed on. And I've heard similar things in communications with my colleagues at OHA about how they're thinking about what falls within a covered benefit and what doesn't, and what a birth doula is allowed to do in a member's house in terms of what gets paid for or included in time. So like I know that there's more on that. My inclination isn't to add additional language to the rule right now for January 1. But if you would like to draft some suggested language and send that to me, then I would be happy to take a look at that, and maybe we can have some email communications with the same list of folks in advance if we are making changes to the text.
Okay, for 1/1/2026.
Yes.
Okay, great. Thank you, Numi. Appreciate it.
Not a problem. Okay. So sort of descending in order of simplicity. Wanted to talk about the coverage limit. I know that there was some confusion, I think, about what that meant. It's written in a somewhat confusing way in the statute, as to say an amount up to but not less than X. In the statute is written as 3,760. The way that I read this with Insurance Brain is to say that you need to have a coverage if you're doing it as sort of a capped benefit. So it would be to say that as a carrier, you will reimburse up to 3,760, but it would not be in violation of this to reimburse more than that. So you could even structure a benefit that has a $4,000 coverage limit, and that's also within that. It's just to say that this is the minimum maximum, so to speak. It is a cap for a year that is the minimum cap that you can set. So as a plan, you have to have a cap that is at least $3,760 for plan year 2026, but you could also have a cap that is more than that. Or you could just have an uncapped benefit that's being reimbursed like other medical services. That's also totally possible and within that. So those things would not be restricted. The only thing that would be restricted is not offering a benefit at all for the services in question, or offering a benefit that is capped for an amount that is less than $3,760. The other thing with this is that I've structured this as plans that were issued, renewed, or extended between January 1, 2026 and December 31, 2026. So it'll roll over in 27. And that, unfortunately, the way that I'm probably going to be updating this rule will be to add a subsection E that says the amount between January 1, 27 and December 31, 27 is going to be X with whatever the inflation adjustment is, and keep on adding to it until I feel comfortable removing previous plan years under the assumption that all relative claims have been paid by that point. So that's kind of what that is, and that's the plan moving forward for inflation adjustment. Questions, comments, or derision for this drafting? Antoinette, I saw you come off mute.
Yeah, I'm talking too much. I think this is my last comment of the day on that. Thanks for clarifying that. I think with what you're planning to do with respect to the cap means that Iraq will probably reconvene every year to basically set that, similar to what we were doing with the insulin copay until that law passed saying that it has to be this copay, period. Okay. My question pertains to the standard plans where it has to be basically apples to apples, origins to origins, right? So should I assume that going forward, the cap would have to be the same for all insurers, right? Who sell products on the marketplace, just the standard plans, because they have to be, apples to apples, origins to origins. So insurer cannot, for example, one insurer cannot, for example, raise the cap to 4,000 for the standard plans only, right? Where another insurer will have it at 3,760. I'm assuming it has to be the same for all insurers for the standard plans on the marketplace.
Yeah, thank you for bringing that up. I think that you are correct, but I would need to do more thinking about that to say, yes, absolutely, that is true. That would be an element that we would need to define in our standard plan rulemaking. But my initial feeling is yes. Did you have another follow-up on that?
Yeah, I guess I'm concerned about 2026. I know the time really has passed. Of course, I don't know what other insurers passed or filed and was approved. But I think that will need to be addressed. I don't know with Katie Button, because the intent of the standard plans is that everything it'd be the same, you know, from plan to plan, or from carrier to plan to plan. So if it's possible to connect with Katie Button to see the marketplace opinion on that, that would be great.
Yeah, no, I have a regular touch point with her, so I'll make sure to pass that along and get back to you on that.
Okay, thank you.
Okay. Other thoughts on coverage limit on the minimum, maximum, or the plan moving forward? Okay, I feel like but that part is pretty straightforward. It's like not quite copy pasted from the statute, but it's pretty close. So kind of potentially the most complicated, or maybe hopefully the easiest part, is like, okay, who gets paid? And so I have pointed to the definition of doula under sub 1A in 4414025 as amended by Senate Bill 692, which was encoded as 2025 Oregon Laws, Chapter 539. And then sort of subsections B, C, and I are, again, basically just copy pasting from statute to say the same things. Coverage requires minimum 24 hours in addition to labor and delivery, option to approve additional, prior authorization, referral, supervision does not apply except for approval of services beyond 24 hours as is permitted to be extended. And the clarification that, yes, this may be subject to the other requirements that apply to benefits under the policy, copay, coinsurance, deductible, et cetera, et cetera. So that's kind of what that is. I guess like the thing that I'm most interested in hearing from folks on is, does this 1A get us where we need to be for January 1? Or is there something additional that's needed for this to get, let me see, Raven, yes. Oh, I have this somewhere. I should have just pulled that up. 414-025 if you want to search yourself, but oh, well, it'll be different actually in the statute. So you wouldn't want to look at the language as it exists in the current ORs. You would want to look at the amended language that is in Senate Bill 692. And I think that the ORs will be, maybe I am looking. Yeah, it's amended in section 141. Doula has the meaning defined 414-025. And then, so it's under section 3 of Senate Bill 692 is added as subsection 9. Doula means a trained professional who provides continuous physical, emotional, and informational support to an individual during pregnancy, labor, and delivery, or the postpartum period to help the individual achieve the healthiest and most satisfying experience possible. Sorry, I only have one screen right now, so I cannot switch easily. Yes, thank you, Donna. The language that is in the statute, in the new statute. That will be in the statute, hopefully on January 1, if LC is keeping up with their job. Okay, I see a hand from Jesse and then from Scott second, and then Raven third. So Jesse, go ahead.
Yeah, thank you. Clarification for 1B. It says that the minimum requirement is 24 hours, but if you add the coverage required, this rule must include a minimum of 24 hours doula services. That would not be the way doula work really works. I mean, if you added up the 2 prenatals, the birth, and 2 postpartums, it's not always going to be based on a number of hours. The birth can be anywhere from a few hours to 3 days. So I'm curious how that translates to pay structures?
Well, so I don't think that, so since this is stated, so B is stated as sort of coverage in addition to labor and delivery. So if labor lasts 7 days, it wouldn't be subject to this limitation. That this is only applying to services beyond labor and delivery. And so it is kind of saying, okay, that this is adding to the requirements that most
That are already
carriers. Yes. Yes. So to say that like whatever is happening with birth itself is not subject to B, that's already being covered in most cases by carriers. So this is just applying to postpartum services. So
I
it's
see.
as a
Okay.
carrier, you have to cover up to 24 hours of postpartum services, or a minimum of 24 hours, and then have the option with prior authorization to extend that past 24 hours as needed.
Thank you for that. I think I just missed seeing the comma in there, and it makes changes the meaning. Thank you.
Yeah, no problem. Grammar will be the death of us all, I'm sure. Scott, go ahead.
I think this just got called out in chat, but Dana clarified that 24 would be pre and post, so it wouldn't just be postpartum for the 24. Just want to throw that out there. Just those two would be outside the L&D, so that would be where that would apply. And then, so thank you, Dana, again for clarifying that in comments. I wanted to address the definition of doulas, and again, I'm happy to get to be educated by providers on the call, because it's just an aspect that we don't typically deal with. And with bills like this, I think it's really important when we're looking at definitions. So when we see a definition such as trained professional, does that to me, it used to be that the statute that it replaced tied to the OHA certification and or registration, but trained professional does not, in my mind, automatically indicate that. And I wanted to, is this in the trying to, with the expansion of these, of doula as a provider type? And I know there's a lot of issues with the writing of this bill, as we're seeing in comments, where again, even the bill seems to set on reimbursement, as you mentioned, Numi, that they set a floor and it really was meant to be a ceiling. I mean, the way it's just not well written. And so why we're taking away OHA registration and certification and replacing it with trained professional. As you mentioned, as issuers, it's from doula coverage, it's very easy for us to say, hey, our members, to make sure you get the best quality care possible, go to the OHA website where certified and registered doulas are to find a doula so we can provide this coverage. And if we go to trained professional, that seems to open it up outside of that. And I wondered if that was discussed, what the intent is, any guidance for issuers for clarification on that.
I mean, certainly I don't have any insights into the mind of LC beyond anyone else. I think certainly that I had many frustrations this year with the drafting of a number of healthcare bills related to insurance, which I think has led to difficulties in implementation kind of across the board, and that we're working through that, and that this is part of that, and moving towards having a little bit more clarity. And some of that is just, I think that there's something that is gained in being an LC drafter for 20 or more years in terms of knowing where stuff is already addressed in a statute or is addressed differently, that like even as a relatively intelligent, talented young attorney coming in and becoming an LC drafter, one might not necessarily know everything that is in the insurance code. Like I don't know everything that's in the insurance code. So this is, yeah. So hopefully we'll be able to kind of clean that up. And that certainly is an issue with the way that this was drafted. It sounds like this is part of what is going to be fixed, hopefully, in the short session. So thank you, Dana, for extending that. Yeah, so I think that the answer is yes, your point is well taken. No, this is not ideal. And hopefully this will be better in the future and that we will be able to point towards something a little bit more concrete than what we have right now.
I'll put it in
Raven.
comments too,
Yep.
Numi. So you'll have a comment. I'll put it in comments too, just my recommendation as well.
Yeah.
And that way you'll have something. And if it's a legislative fix in the short session, you'll just have something from an issue or so. Thank you.
Yes. Yeah, no, I certainly appreciate written comments on this. It's sort of my scope of likely changes is like, if it's not completely on fire, then I'm probably not going to change it before January 1, but it will certainly inform drafting for the permanent rules. It's not to say that I won't change anything, but it's kind of like my hope was to expose something that's as close to final as we can on a relatively short timeline. Let's see, I saw Raven next.
Thank you. Yeah, my comment is about this as well, like how we define doulas. On one hand, that definition is like this super broad. That is true. That is a true statement about doulas. It is going to be super useless for actually implementing things here. So I would really recommend something more specific. An example, so in Oregon, they already have the traditional health worker approved doulas. There's also lots of other kinds of doula trainings nationally. So when you have like military insurance benefits for doulas, they won't recognize the state approved doulas, but they will recognize like a couple random trainings that are on their special list, and then they exclude a bunch of others. Same with United Healthcare or a couple others who are like, oh, well, we'll accept you because you have this old thing, but not you because you have the current like state certification. So I would strongly recommend that we have clarity there. So there's at least a baseline. Like my recommendation, and I can put it in the chat, is that automatically traditional health worker doulas would be accepted. Like if they make a claim, even if they aren't in network maybe, but like they are legitimately approved as doulas and could just like make those claims. And if you wanted to open it up to wider like DONA doulas or DTI doulas or whatever they've taken the training, the individual plans could outline that if they wanted to have like a broader network, but like minimum THW doulas, please.
Okay, thank you, Raven. Yeah, I think with the statute as it's currently written, to some extent, I'm kind of stuck. But so certainly like lots to think about as we kind of move towards permanent rulemaking and having this long-term implementation of this benefit. Looks like I have Antoinette and then Sean.
Yeah, and thanks for everybody speaking up, especially the doula community. I'm learning so much. One question I had, and this is kind of tagging on to Scott's question. I just wanted to clarify, and I think Numi, you probably answered my question, that obviously we're stuck with the legislation. So I understand, again, we are not taking away from what is currently happening, and please do a community correct me on this or set me straight, is that for if you want to become a doula, you do go through the OHA currently, you apply to get your certification, correct? And you have to meet certain requirements in order to qualify to provide doula services. Am I correct?
Do we
And
have
this is for the
somebody?
doula community.
Yeah, I might be able to answer that for you. This is Sean.
Okay.
So I'm one of the program analysts for the traditional health worker program, and that is correct.
Okay.
Yes, to be able to provide doula services to Medicaid recipients in Oregon, you have to be certified as a traditional health worker doula, birth doula, to be able to go out and provide those services. And the intent for the postpartum doula is just to enhance, add another worker type to be able to continue doing that work, because there's clearly limitations with only the 3 postpartum visits that birth doulas have. So a lot of this, as was already stated, we're the details aren't going to be hashed out until the racks happen, right? So we're being really cautious about what we're telling folks out in the community, because there's still so many moving pieces to this. So I just want to caution folks about getting too far ahead, because there's many racks that are coming down next year that are going to impact this conversation. Thank you.
Thanks for the clarification, Sean. I guess I was coming from the approach that at least, in the healthcare provider operations in Oregon, for any provider to provide those kind of services, they need some kind of licensure within the state that they provide the services. So it's good to know that there are other organizations, I guess, because I see in the chat, Donna is one of those organizations where you can be, do you get a certification from them in order to provide doula services in Oregon, where you don't have to go through the OHA? I guess I'm just trying to understand where Donna comes in, the organization comes in to play.
Wendy, do you have a response to that?
Yes, DONA's been probably the oldest and most recognized doula training organization in the world for many years. And so when you see the research and you see a lot of legislation, you're going to see DONA people, DONA doulas that are part of that. And in other states, unlike Oregon, for most of their Medicaid, they will have options. You can take a variety of different doula trainings and then apply to the state. Here in Oregon, what's happened is there's been some gatekeeping that's occurred. And so they require now that the certification be done through the state of Oregon in order to get state certified to be able to take Medicaid here in Oregon. DONA has been certifying doulas long before insurance was paying doulas. And so that's why you're going to kind of hear them. Ideally, what would happen is you would have a set kind of requirements that come from a training. And when they apply, that would be the determination, not that has to be a state approved training, because by making it be a state approved training, what's going to happen is you're going to have doulas that move to Oregon, and are they going to be required to have to take a new workshop in Oregon in order to get certified, where they might have been certified through DONA already for 15 years to providing care in another state. So by opening it, it allows more access to doulas, because then doulas are not going to bill insurance or not provide super bills if they have to then go through one of the 6 organizations that Oregon has said should be training doulas. So that's really the background. DONA's been around for a long time.
So in response to that, then shouldn't that be something outside of this rulemaking and an issue addressed with the OHA? Perhaps having that conversation with them to be able to incorporate the training requirements from the OHA into, as I guess, how can I say this? In that, if you do go through that comprehensive DONA training, which hopefully includes includes all the requirements in Oregon, then that should suffice in terms of being able to practice in Oregon. So I just feel like maybe that is like a separate conversation with the OHA to make adjustments in your rules or something like that in order for that to happen, just based on what I'm hearing. But again, I could be wrong. So
Well, I mean, I appreciate the sort of thoughts, and thank you, Wendy, for that information. That's very helpful. I think so. certainly there's a lot of feedback. I haven't necessarily heard anything that makes me think that this rule text is drastically broken as it currently exists. I see your hand, Stacy. I'm going to go ahead and say that I'm not going to be calling for additional sort of discussion on the draft immediately, except to say, so kind of the way I have my agenda structured is like normally we have space for public comment. I've more or less treated the entire meeting as public comment. Rather than discriminating between sort of official formal RAC members and the sort of doula community more broadly and all of the interest that there has been in that. And I appreciate the sort of that even with me not directing traffic as much as I usually do in this type of meeting, that the conversation is kept pretty much on track and has remained respectful and professional, and that's all great. So thank you for thank you all for your professionalism and your thoughtful additions here. So I think before I move to next steps, is there any final thoughts that people want to put on the record before I kind of go over where we're going next? Okay.
Numi, this is Antoinette. I'll probably provide this in a comment letter, but just also wanted to clarify that obviously that this applies to doula services in Oregon provided by I guess a doula certified in Oregon. I just want to make sure we understand the scope of the services. And I'm happy to put this in comment letter too. Because it mentions a health benefit plan as defined in ORS, the citation in this state. That's why I just want to make sure we're interpreting the law correctly.
No, I hear the sort of thought, and like I don't think like I'm in any way qualified to get into sort of a inter-doula conversation about DONA versus the traditional health worker certification. Like certainly I would appreciate comments from folks on kind of thoughts about how we can best address the definition of doula that we have in statute. And maybe that is to say something along the lines of, I could add a second sentence to A that says something like, we would consider it adequate to be have your traditional health worker certification from Oregon or to have a certification from DONA. And that's what we would run with for the temp rule. And I now that I have said that out loud, that's kind of what I'm leaning towards doing at the moment. So I would certainly appreciate thoughts on that approach. Or if anybody's seeing glaring problems with that, then yeah. Wendy, go ahead.
I would encourage you to look at what TRICARE is doing for their doula program, because they have a set of programs that they have deemed as like, if you're certified through one of these organizations, then you can bill TRICARE. And we worked really hard to get them to accept Medicaid certified doulas, because Medicaid certified doulas are usually more qualified than, say, DONA doulas or CAPA doulas or whatever. But they've kind of carved out a number of programs that they deem as acceptable. And of course, THW doulas, Medicaid doulas are one of those types.
Okay, thank you. Thank you, Wendy. All right. Other thoughts before? Okay, not seeing any additional hands. So sort of next steps, I think so I'm a little bit less bound by strict timelines than I would be with the formal rulemaking. So I think what I would say, let's see. I think we will try and get everything ready to file at the beginning of December. And so if you have comments, if you have additional things, and I appreciate like all of the written stuff that I can get, because like I will have a transcript of this meeting available, but it will be helpful to me to have organized thoughts from the various parties. Like, how about 2 weeks from today, which would be November, it's Thursday. November 13 would be sort of a good timeline for people to get any written thoughts back to me. Just to mention again, sort of, I ended up going through a lot of next steps at the top of the meeting just because of the nature of this particular project. But really the plan is we'll get a temp rule out. I will take comments into consideration and potentially, I think the only thing that I am feeling there might be a call to expand would be pushing on the doula definition in some way to add some additional clarification on the certification that would be adequate for the time being. Have the temporal in place for January 1. That is effective for 6 months. OHA is conducting rulemaking with the Health Licensing Office in March of 2026 or so. See how that process goes. Hopefully we'll have some questions answered. And we'll also be going past the short legislative session where it seems very, very likely that there will be some tweaks to the language of the law as it was implemented, as it was written for Senate Bill 692 this year. So lots of things coming up, lots of contingencies in there. And I will look to reconvene some version of this group Marchish, because we need to be kind of working on having a filing ready in April to have an effective rule at the beginning of July, which is not ideal, but kind of tight. And thank you all for the robust conversation. I think I have some better ideas about precisely who I would like to invite to be formal RAC members in the spring, and punishment for doing good work, I suppose, for folks who spoke up a lot. As well as, like, just as sort of a heads up, I will probably be doing more traffic control in terms of who I am accepting as speakers during the body of the meeting. So look forward to that. But thank you all for being very respectful and containing your comments appropriately today without me doing that. Let's see, Raven, go ahead.
I'm wondering if it's also up for discussion or in the rules, like if we can do any alignment of billing codes and diagnosis codes, or is that like completely up to the commercial insurers? Just because I know it will be a nightmare for individual doulas to like have to figure out, like, how do I bill for this? How do I code for that? If it's all kinds of different things. Like, are we able to kind of request that that we use the similar billing codes and diagnostic codes if we're using the same fee structure?
So my initial response is that's beyond what we would usually put in rule on things. There has been guidance occasionally for specific things, but certainly I'll take that under consideration as we're moving forward. And I am hoping for the final product of the formal RAC process to be more robust than what I cobbled together for today. So thank you for that input, and like I'll keep that in mind. Donna.
Yeah, I would just add that the statute itself does direct private insurers to seek to implement the private insurance portion of the bill in alignment with what Medicaid already does, to the extent practicable, or whatever legal word they used in that setting. So there is some, even if you don't see it in rule, there's still statutory guidance pointing private insurers in that direction that hopefully will play out in all the, pieces that go beyond rules too, like those guidance documents that sit underneath sometimes the rule level of information.
Yeah, thank you for that. I do see comment from Iris. You were actually on my list, but I don't think I had the right email address. So go figure. Let's see. Thank you, Raven, for the additional questions. Okay. So I think I'm gonna roll more or less with what I said that I was gonna do, which is like maybe tweak the language on the definition of doula and what we're accepting to be a little bit more broad and therefore in alignment with the statutory direction that we're getting from 692, but like not pushing the envelope beyond anything that anybody said. I'll welcome all written comments and I will read all of them. And looking forward to hearing feedback. Please send me an email that says you are interested in participating in the formal RAC when I do convene that in the spring. I do see, yes, thank you, Iris. I do see that we had a few people who spoke up in chat, but like, please let me know if you're interested and I'll have a more formal list drawn up before then. Yeah, and I think that is everything for the moment. Thank you all for your participation and interest, and I'll be looking forward to continuing this conversation in the spring. Thank you. Well, good afternoon.
Thank you, Naomi. Bye.
Thank you.